Hey, what's going on? Today we are going to be talking about managing objections, which I love as a topic. I think that it's one of the most critical things that we can practice and that we can get better at as audiologists as we're trying to get a higher acceptance rates, more people moving forward with treatment. So let me pull up my PowerPoint presentation here. All right, let's jump right in. What are objections ultimately? An objection in practice is anytime a patient either gives you a reason they want to end the appointment, or gives you an excuse, or is they say something that indicates that they are not interested in moving forward. And whether it's I need to think about it, or that's too much money, or I need to talk to my spouse. Ultimately, it's a way to get out of the appointment without accepting the treatment recommendations. What are they really? Really, objections are just unanswered questions. They're just things that the patient or the prospect doesn't totally understand well enough, or we haven't addressed well enough for them to feel comfortable enough to move forward with the solution that's the right fit for them. They can be topics that the patients defer to if they don't have enough understanding of the value of the recommendation. So, money is a common one here. If people don't really know what to talk about, they talk about money. If something seems expensive because we haven't done a good job of establishing and building the value, then the patient is more likely to give you money objections. But really, that's just something the patient is deferring to because that's what they understand. They're able to talk about that because that makes sense to them. And finally, their unresolved concerns. Here's some common objections when it comes to hearing aids. Too expensive, can't afford it. I can get it cheaper from Costco. I'm going to use my insurances, especially with the 3PAs now that those are more common for clinics that are not accepting those or that are trying to convert those into private pays. Maybe they opt to use their insurance. I don't think I have enough of a problem yet, right? That's a denial objection. I need to think about it, or I need to talk to the decision maker. So, kids, spouse, whatever the case might be. These are all common hearing aid objections that we need to get really confident and comfortable in managing so that when we get in front of a patient, we're not stumbling trying to think of what to say. We're just ready and it just comes out automatically. Why do these objections happen? And then ultimately, the question is there anything we can do to preempt objections from happening in the first place? So, some reasons that they happen is if we didn't get commitment or buy in before we presented the treatment options. This one's something that we can always get better at, but I think is so critically important. When you're talking to a patient and you're talking about treatment recommendations, you really want to make sure that the patient has expressed to you that they want to treat the problem and that they agree with the solution that you've recommended for the problem. So you want them to verbalize that, yes, they are interested in your treatment recommendation, and yes, they are willing to move forward. And now it's just a question of logistics. How do we make sure the finances and everything make sense and work out? Objections can happen because we didn't ask enough questions. So we didn't get a good enough understanding of what the core concerns, preconceived notions, beliefs, et cetera, that patient or prospect had coming into the appointment. And if we don't ask the questions, we're not able to address those issues before they become a problem. We didn't preempt common questions with education during the first component of the appointment. So the way that Audflow is structured is it's designed to give us opportunities to preempt a lot of the common questions and objections and concerns that patients come up with before they're a problem. So we want to make sure that we are addressing the elephant in the room and that we're being proactive about, if we know that there are things that are going to be objections, then it's better to preempt them up front rather than wait until the patient's asking the question when they're thinking about moving forward with the treatment decision. And then finally, the prospect might just not be a good lead. So they might just genuinely have no interest in treating their hearing loss, no sense that they have a hearing difficulty. And for these people, we can stay in touch with them. We can use our tested, not treated automated follow up systems. But ultimately, at that point in time, they're not an ideal prospect. So, the biggest thing we can do to preempt 90% of the objections that would potentially happen during appointment is asking versus telling. So, we want to ask questions, ask questions, ask questions. If we're talking, we're selling. If we're asking, we're pulling and we're guiding the patient towards closing themselves. So, we can tell if we tell somebody something, we're pushing them away, especially if they're ambivalent about their hearing, if they're not really sure that treating their hearing loss is what they want to do, if we're telling them, if we're trying to educate them and tell them, hey, this is what you need to do, guess what? That feels like we're pushing our ideas onto them. If we ask questions, then they can take ownership of the solution and we're pulling them towards the solution and allowing them to feel the sense of autonomy that they're making their own decisions. How do we do that? We need to ask questions that lead them to taking ownership of their hearing difficulty. So we need to establish what are the key areas where you're having listening difficulties. We need the patient to tell us, how does that make them feel? How is that impacting their life? Who is it impacting? What interactions is it affecting? We need them to verbalize these things to us. Which leads into the next one. They need to express the challenges that their hearing creates in their life. It's just taking ownership. It's just making sure that they have totally acknowledged that there's a problem and that they're seeking a solution. And so then the only thing that we have to uncover is, what is that solution and are we a good fit to work together? Before they move forward with before we have the price discussion, we need to make sure that the patient acknowledges that they want to move forward with hearing aids. So this is one that we see in our clinic that we work on, and it's really something that you need to stay top of mind with, and especially if we have um, audiologists that haven't been in a private practice setting or haven't sold hearing aids in the past. We need to make sure that we are getting the patient to acknowledge they want to move forward with hearing aids, because if they haven't told us, yeah, I'm willing to wear hearing aids, or I'm excited to wear hearing aids, or I really want to do this, it's going to make a big difference in my life. If we haven't gotten that, if the gears are still turning in their mind as to, like, is this something I actually even want to do, then guess what? As soon as we spring a price tag on them, they're probably not going to move forward, which just makes sense. If they're not even bought into the treatment solution, and then we put a big price tag on top of that, we have to get them where they've acknowledged that they want to move forward with the solution before we have a conversation about price. If we can't get them to that point, you know what? Maybe we do different things. Maybe we do a demo. Maybe we reschedule with the spouse. Maybe we let them think about it for a month and have a time for them to come back in before we talk about price, right? If we haven't gotten the buy-in that they want to move forward with treatment, we don't talk about price. And then finally, we have to establish if they're able to make their own buying decisions. So this is another reason that patients don't move forward. If the decision maker isn't present during the appointment, then there's a good chance that they're not going to move forward with treatment. They're going to say, I need to talk to my kids. I need to talk to my spouse. This is where working with our front offices and getting them really comfortable, trained, asking to have a companion come to the appointment makes a big difference. I'm going to say it again. Stop talking, start asking questions. If you're pitching, your patients will feel that. They'll shut down, they'll become distrustful. You will lose their trust. If you're telling, you're selling, if you're asking, the patient is closing themselves. They are guiding themselves to their own treatment solution. And the key is you have to ask good quality, open-ended questions. So we're not talking yes or no questions, but open-ended questions so that the patient can guide themselves to a solution that's best for their needs, and they're not going to feel like they're being sold to. This is a key concept because a lot of what we want to do during a consultation is we want to be in control of the conversation, which doesn't mean we're talking the whole time. In fact, on the contrary, we shouldn't be talking all the time. We should just be asking really good questions that are guiding the direction of the conversation. All right, objection categories are money, which can be a true financial concern, or it can be kind of a red herring where it's not actually a true money problem, but money is what they're using as kind of the excuse to not move forward. I can't afford it, or that's a lot of money. I've heard I could get it for less. Or sometimes a true money objection can be, I need to think about it, but they're not telling you it's too expensive for whatever reason. Denial is another category of objections. I'm going to wait until it's a bigger problem. I don't think I really need that much help. I only need help hearing in certain situations. These are all denial objections. But if we're getting these objections, that means we've moved forward with presenting treatment recommendations before the patient has acknowledged that they agree with the treatment solution, right? Most of the time. No companion. So if a decision maker isn't in the room, or even sometimes the companion can kind of be an out for people. So I need to talk to my spouse. I never make decisions without my spouse. My kids handle my money. That last one can truly be like, we actually need the kids involved in the conversation. We should have identified that earlier, but let's now move forward with an action plan to get the kids involved in the conversation. But again, this is why it's critical to train our staff on getting a companion to the appointment, and we should track that, and we should see higher than 50% of our appointments with companions present. Finally, no trust. This one is tricky. Patients often don't say that they don't trust you. In fact, they almost never say that they don't trust you. Typically, they'll say, I need to think about it. They might even say, you did a great job, but I never make a buying decision at my first appointment, or I'll get back with you. The no trust can be tricky because if you didn't establish trust, you might not be aware of it if you're maybe a less experienced or less perceptive provider. But this is a real one, and this is a big reason why people don't move forward with care. It's a big reason why we've created Audflow, so that we can have a guided presentation. So every one of our providers is creating that same really immersive experience for our patients to build their trust. This one is almost impossible to overcome. If they don't trust you, then you're not going to manage objections out of that hole that you've already dug for yourself. You've got to work on the front end and take that as a learning experience, but you've got to work on the front end of your appointment to work on building trust, because once you lose it, it's really hard to get it back in that short little appointment. All right, here's how we manage objections. I call it the AAA method: acknowledge the question, address the core concern, and ask a question. So we're going to practice a few of these. I've had some people tell me they have Costco's in their area. So maybe the patient says your price is higher than your competitors. At Costco, I can get premium hearing aids for $1,700. So we acknowledge it. I totally understand. Address the concern. When I'm making purchases, I'm always looking for ways to save money too. And then ask them a question. Tell me, if our treatment plan was the same price as their hearing aids, would you work with us? Now, notice there is a subtle kind of language differentiator in there. I said treatment plan for us and hearing aids for them. I think that's valuable. Patient might say, well, if it was the same price, I'd definitely rather do business with you. Okay, cool. So we've gotten them to acknowledge that on a level price playing field, they would rather work with us. So let's ask some more questions. That's great to hear. Why would you rather work with us if the price was the same? Well, because you guys do X. You guys do real ear measurement. I really feel more comfortable with the professionalism in your clinic. You guys have doctors of audiology, whatever the case might be. And you acknowledge that. Yes, that's true. In fact, that's one of the reasons that our patients really value us and tell us that they're glad they chose to work with us. I'm sure you can see why we charge more than Costco, right? So would you like to get the process started so we can help you get back to hearing better? We can go ahead and ask them if they'd like to move forward, because they've told us that they'd like to move forward with us. Now we can see if they keep pushing in the price objection, and then we need to start asking more price clarifying questions. But you can see with this one, you have to have some questions in your tool belt, because the conversation is never the same. It's always fluid. It's always improvisational. So you have to be ready to go with good questions so that you can guide the conversation in the direction you want to. So here's a money objection, and money is a pretty common one, and there's a lot of ways to handle money objections. Here's one example. I totally understand. A lot of people that I talk to initially feel that treating their hearing loss seems like a large investment, but my patients consistently tell me that it's one of the best investments they've ever made. let me ask you, if you could do X, Y, and Z, which is where we're inserting their listening environment. So if you could go to restaurants, if you could be at home with your spouse, and if you could be with your grandkids and confidently hear what was happening in all those situations for years to come, would that be worth the investment of X to you? So with this, we're establishing if it's an actual money objection or if it's a value objection. A value objection means that it's not that they don't have the resources, it's that they don't think that the value of the solution we're creating is worth the amount of money. So that's where we need to remind them what it is they're investing in. They're not investing in hearing aids, they're investing in playing with their grandkids and being able to hear them, right? We're tying it back into the emotion, back into what's relevant to them. I need to talk to my spouse. I totally understand. I'd like to talk to my spouse before making a big decision too. I know you said your wife is one of the big motivators for you coming in today. What do you think she would say if she was here with us right now? This is a really good one because people know their spouse, they know their family, they know their loved ones. And so if we ask them this question, 9 times out of 10, they're going to say, well, she'd tell me to go ahead and move forward with it. Okay. So did you have an idea coming in, what the cost would be? It might be that they didn't know what the cost was going to be. We can ask more clarifying questions to understand, do they actually need to talk to their spouse, or is that more of an excuse so that they don't have to make a decision right now? In some cases, I'll say, how about you call your spouse? I need to step out and do a couple of things in the room next door. I'll give you 5 minutes to talk to your spouse and then I'll come back in. Sometimes it's as simple as that. All right. So the way that we practice this is by role playing. You need two people. You get one person to be the patient, one person to be the clinician, and we go through scenarios, right? The person who's the patient tells you who the character is. It might be a character of a patient that they saw last week that stumped them with some challenging questions or that they ended up not converting. And then you guys just role play it out. You just go through the session. Rules to role play: you can't time out. You can't say, oh, geez, I messed that up. Hold on, let me go back. None of that. You have to act like you're with the patient, which means if you screw up, you got to keep going. You got to power through it. Keep it short. So you don't have to role play an entire consultation. Just role play one or two objections so that you can really get them ironed out. In mountain biking, they call that sessioning. You're sessioning something that's challenging. You keep doing it over and over again until you get the hang of it and until it just becomes muscle memory. Same thing here. Just session the same questions over and over again until you feel really confident asking good questions and guiding the patient into the direction of action. Repetition's key. You just got to keep doing it, right? Muscle memory. You got to build the muscle memory. Now, the person who's playing the patient needs to offer constructive feedback, and the person playing the provider needs to be open to feedback, meaning you can't argue, you can't be combative, you have to accept it. It's okay to ask questions. It's okay to try things and say, oh, I actually would rather do it this way. The feedback doesn't have to be, you don't have to take it as golden truth, right? You can take it with a grain of salt if you don't agree with it, but try to be open-minded. Try to think that maybe when somebody's seeing you from a different perspective, they might be able to offer a different way that you can approach these objections that you're having difficulty with in the clinic. All right. That's it for the objections presentation. I hope this was helpful today, and I'll see you guys in the next one.